Alrighty, welcome to my master's thesis presentation. This talk will be on dynamic respiratory tracking in the presence of cardiac motion for stereotactic arrhythmia radioablation, or STAR. My name is Katya Nell, and I was supervised by Dr. Stephen Thomas. And before we start, I must just comment on the fact that I do think it's a little serendipitous that I started out in astrophysics as an undergrad, actually, and managed to still end up working on some kind of star-related thing for my master's research. But anyways, as an overview of what we'll be talking about today, we will start off with a bit of an introduction, which will include an overview of how the heart works and a disease called ventricular tachycardia, and then we will discuss some traditional treatment methods for ventricular tachycardia, as well as the novel treatment STAR. Then we will cover the development of a cardiac phantom for the experiments we wanted to carry out, how the data was collected for those experiments, results of the experiments, and a discussion of those results, and of course we will end off with the limitations of the study and the conclusion. So let us begin with the introduction. So here we have a diagram of the heart and the blood flow through the heart. The heart is pretty important. It is what drives blood circulation throughout our bodies, and we do need blood to be circulated so that the blood can carry nutrients and oxygen to cells and systems around our bodies. So blood circulation relies upon coordinated contractions of the atria, which are these smaller chambers up here, and the ventricles, which are these larger chambers down here. Blood flows from the atria into the ventricles when the heart relaxes through the tricuspid and mitral valves, and then gets pumped from the ventricles into the large arteries, the aorta and pulmonary artery, during the ejection period. This is a very hard-working organ, and it'll beat a little over 3 billion times in the average person's lifetime. But the part of the heart system that we care about most for this study is actually the electrical conduction system, which is what drives the pumping of our hearts. So most cells throughout the atria and the ventricles are at a resting potential in the absence of stimulation, and then they depolarize upon arrival of an action potential, which causes the myocardium, or the heart muscle, to contract. There's a small group of cells, called pacemaker cells, clustered here at the top of the right atrium, and they constitute the sinoatrial, or SA node. Now, these pacemaker cells do not have a resting potential like the rest of the cells. Instead, they depolarize until they hit a threshold potential and then repolarize repeatedly, hence their pacemaker moniker. So the SA node sends out action potentials, which travel through the atrioventricular node, through the bundle of His, and then through the Purkinje fibers. Now, any structural defects or faulty conduction of these electrical signals can lead to some pretty serious medical issues. In order to check for any issues with the electrical conduction system, we have a test known as an electrocardiogram, or an ECG. So ECGs are recordings of the voltage measured over time from the heart, and they're done by placing little electrodes over a person's body. Now, a single beat from a heart in sinus rhythm, or a regular healthy rhythm, is shown here. Looking at some of the major features of this, the P wave corresponds to the contraction of the atria when the atrial cells depolarize. Then the QRS complex corresponds to the contraction of the ventricles when the ventricular cells depolarize, and this is typically about 80 to 100 milliseconds long. And then finally, we have the T wave, which corresponds to the relaxation of the ventricles when the ventricular cells repolarize. Now, you may have noticed I didn't mention atrial repolarization, and that's because it is obscured by the QRS complex, so we don't actually have a feature corresponding to it here. Now, any departures from this model behavior, such as extra or missing features, elongated or shortened intervals or segments, or any differing amplitudes, can potentially indicate medical concerns. Now, cardiovascular diseases are the leading cause of death across the world. Some examples include coronary artery disease, pericarditis, heart failure, and arrhythmias. Cardiac arrhythmias are the subset of cardiovascular diseases affecting the cardiac electrical conduction system, and these can range from benign to life-threatening. Arrhythmias include types of abnormally fast heart rate, or tachyarrhythmias, abnormally slow heart rates, or bradyarrhythmias, as well as just otherwise irregular heart rates. Ventricular arrhythmias, a specific type of arrhythmia, affect only the ventricles of the heart. An example of this are premature ventricular contractions. These are somewhat common and usually benign, and often feel like a skipped or extra heartbeat. I myself get these and often describe the sensation as the one you get when you miss a step on the stairs, but many people get them without even having any symptoms. However, if these occur frequently, they can indicate some other issues. A much more dangerous type of ventricular arrhythmia is known as ventricular tachycardia, or VT. So VT is characterized by a rapid heart rate originating in the ventricles of the heart, specifically a combination of a wide QRS complex. Now, if you remember, we said a normal QRS complex is about 80 to 100 milliseconds wide. So with VT, we have a QRS complex over 120 milliseconds wide, as well as a heart rate of over 100 beats per minute. Now, VT is most commonly caused by myocardial scar tissue, which can be formed as a result of myocardial infarction, or heart attack, or cardiomyopathy. This scar tissue provides an electrical pathway for re-entry, a concept I'll go over in a second. But importantly, left untreated, VT can convert to ventricular fibrillation, which is a cardiac arrest rhythm and can very quickly result in death. So this is not a disease we want to wait and watch. This is something we do need to treat. So here on the top left, we can see a graphical representation of healthy myocardium, which has a fairly uniform structure, and that allows for action potentials, indicated by this arrow in blue, to travel fairly cleanly through the tissues. Now below this, we see a representation of myocardial scarring, wherein these uniform tissues of the myocardium were damaged by, say, a heart attack. And scar tissue here you can see in this tan color, which then interferes with those electrical signal conductions. So you can see the blue arrows are kind of just all over the place here. And on the right here, we can see an image where white scar tissue is intermingled with the healthy red tissue, which again messes with the conduction of those electrical signals. As another representation of this, here we have a video showing a slowed down version of the electrical signal propagating through the myocardium. So in healthy hearts, this signal should be initiated exclusively from the sinoatrial node. However, here we can see this signal indicated by the sort of swooping wave in the yellow arrows is re-entering here where this dotted yellow arrow is. So instead of just originating from that pacemaker of the heart, we also have this signal re-entry, which then leads to ventricular tachycardia. So some common treatments or traditional treatments for ventricular tachycardia include antiarrhythmic drugs or AADs, implantable cardioverter defibrillators or ICDs, and catheter ablation. So starting off with AADs, there's only one class of them, beta blockers, that actually are effective, I suppose. In clinical studies, for the most part, anything besides beta blockers, so any of the other three classes of AADs, have pretty large adverse side effect profiles, and they aren't always effective at actually reducing mortality rates due to VT. Beta blockers are okay at these things and don't have too many adverse side effects, but they're still not that effective, so they typically need to be used in conjunction with other therapies. Now, one of those other therapies are ICDs, which are surgically implanted devices that deliver shocks to the heart when it detects arrhythmias, which are effective for reducing incidence of sudden death due to ventricular arrhythmias. But ICDs are not 100% effective, and there are inherent risks with the implantation procedure, such as infection, lead dislodgement, and other adverse events. So the other major thing with ICDs, though, are appropriate ICD shocks, so shocks that the ICD delivers when it should and not inappropriately, are actually linked to an increase in mortality rates, which is not to say that ICDs are a bad thing, it just indicates that the need for an ICD in the first place should prompt other additional treatments. So then the third option, catheter ablation, is a procedure in which a thin tube is routed through a blood vessel to the heart in order to form new myocardial scars intentionally that can block the abnormal electrical impulses responsible for the patient's arrhythmias. So essentially it targets any non-scarred tissue within the pre-existing scar to prevent re-entry. Now, clinically speaking, catheter ablation does reduce VT recurrence and the need for ICD shocks in patients with ICDs. But again, long-term success rates only range from about 50 to 70%. The treatment can come with complications, as with any surgical procedure, and for some patients, anatomical factors may make treatment ineffective. So many patients don't adequately respond to any of these treatments, meaning we need something new. Now, the foreshadowing's already there. We saw that on the opening slide. But before we can actually talk about that novel treatment star, we do need to make a detour to talk about radiation in medicine in general. So first, let's talk about the two major applications of radiation in medicine. Those are medical imaging and radiation therapy, both of which utilize the properties of ionizing radiation. So as a reminder, ionizing radiation is any type of radiation that has sufficient energy to ionize atoms or molecules it encounters by knocking out one or more of their electrons. Radiation is what makes imaging, such as X-rays, CT scans, and PET scans, possible. But the other application of radiation in medicine is the one we'll be focusing on more, and that's radiation therapy, which is most commonly used for cancer patients. Radiation therapy takes advantage of the damaging effects of ionizing radiation to target cancerous cells in tumors and cause cell death. Now, the major goal with radiation therapy is to minimize healthy tissue irradiation and focus on damaging the target effectively. And this goal is something I will continue to re-emphasize throughout this talk just because of how important it is. So radiation treatment planning is a fairly complex process, as every patient has unique anatomy and target structures. And during radiation treatment planning, we have 4 major volumes of interest. The first volume of interest here in the middle is the gross tumor volume, or the GTV, and this is the visible extent of the tumor. So if you can imagine taking a pen and drawing an outline around the tumor, that's the GTV. Then we have the clinical target volume, or the CTV, which includes the GTV plus a margin for any microscopic tumor infiltration. Now, for non-cancerous targets, GTV and the CTV would be the same thing, since with non-cancerous targets, we don't have to worry about any microscopic infiltration. Next, we have the internal target volume, or the ITV, which includes the previous margins plus an internal margin to account for motion and other internal shifts of the target and organs. And then finally, the PTV, or the planning target volume, includes all the previous margins plus a setup margin to account for any inaccuracies arising from patient setup and treatment delivery. So this planning process is a balance between ensuring the CTV receives the necessary dose whilst sparing any organs at risk, or in other words, trying to ensure the CTV receives the necessary dose whilst minimizing the size of the PTV relative to it. Now, along with careful planning and methods used to consistently reproduce patient positioning, there is another key method used to reduce healthy tissue irradiation in traditional radiation therapy. And this is fractionation. So traditional radiation therapy is fractionated, which means that treatment is split up into multiple doses spread over the course of weeks or even months. This is because healthy cells can recover more quickly than cancerous cells from radiation treatment. So fractionated treatment allows healthy cells to recover between the sessions, which would reduce the severity and frequency of adverse effects due to radiation therapy, while still effectively targeting the actual cancerous target. Now, a non-traditional radiotherapy method called stereotactic body radiation therapy, or SBRT, instead uses several radiation beams at varying angles relative to the target to achieve a highly conformal, high-dose delivery with steep fall-off over the course of a single or small number of fractions. Now, this has direct patient benefit in that the treatment is concluded within a matter of days rather than weeks or months. But note that SBRT doesn't target microscopic spread of disease, so it's most appropriate for well-defined targets, such as non-cancerous targets or very early-stage cancers with a well-defined gross tumor volume. Now, the important thing with SBRT is that because it is in a single or small number of sessions, it has that extremely high radiation dose. And due to that extremely high dose, minimization of errors resulting from patient repositioning and organ motion is especially crucial. Now, a particular type of SBRT applied to cardiac targets is stereotactic arrhythmia radioablation, or STAR. So STAR aims to ablate arrhythmogenic myocardial scar tissue driving re-entry, which is similar to the purpose of catheter ablation, but with the benefit that it is non-invasive. No tubes are getting routed through blood vessels to your heart, you're just getting hit by a radiation beam. Now, clinical studies have found acute reductions in VT burden via STAR treatment, but these studies do emphasize the need for future studies to focus on reducing incidence of treatment-related adverse effects. In this case, minimizing healthy tissue irradiation is particularly difficult due to the cardiac and respiratory motion of the target. And to help visualize how large of an impact those motions have, we have a little video here showing the heart beating as well as the patient breathing in and out. And you can see that if you imagine any point on the heart there trying to target it with a radiation beam, there is a fair bit of motion occurring there, and we can't exactly turn off a patient's heart or breathing during treatment. So we need motion management methods. Some of these methods include motion encompassing, breath hold, abdominal compression, respiratory gating, and dynamic tracking. Now, I won't go over all of these in detail, but as an example, the first one, motion encompassing, is a method wherein the entire volume traced out by the motion of the target is irradiated. And as you can probably imagine, this does lead to a lot of healthy tissue irradiation, so it's certainly not ideal. Another option, called respiratory gating, turns on and off the radiation beam as the target moves in and out of a specified region in order to reduce that healthy tissue irradiation, but this increases treatment duration since the radiation beam isn't on for the entire duration of treatment. And it's also just not 100% effective. So the option that we'll be looking at the most here is dynamic tracking. Now, dynamic tracking continuously adjusts radiation delivery throughout the treatment period, which reduces the necessary PTV coverage without sacrificing treatment time efficiency. The way this works is dynamic tracking uses a correlation model between internal and external motion, which is generated prior to treatment. The external surrogates are typically infrared markers placed on the patient's chest, and then kilovoltage X-ray fluoroscopy imaging of the target would be ideal for the internal target, but if the target is not visible, then a high-density surrogate can be used, such as stents or fiducials. In particular, star targets are not readily visible on fluoroscopy sequences, so internal surrogates such as ICD leads can be used. And now ICD leads are particularly useful because many star patients already have them implanted, so we don't need to do an extra procedure to implant fiducials for them. And here we have an example of ICD leads. So this patient, I believe, does have an extra ICD lead compared to usual. They have one abandoned lead, and some patients may have more or less leads overall. But the idea is that these lead locations, which are clearly very visible on this X-ray imaging, can be used to triangulate the target position. Now, with all of this being said, what is the point of this study? So we have two major things we know about. One, respiratory motion plays a larger role than cardiac motion in affecting target localization. So we do want to focus on tracking respiratory motion. But the other thing we know is that cardiac motion interferes with the quality of this tracking based on a phantom study done using sinusoidal waveforms. So what would happen if we used realistic motion traces from patient data instead? Well, this leads us to our two major questions for this study. One, what is the efficacy of dynamic tracking using a correlation model trained on cardiorespiratory motion using realistic motion traces from actual patients? And then two, is there a benefit to filtering out the cardiac component of the motion prior to training the correlation model? Well, in order to explore these things, we need to look at a cardiac phantom. So for this study, in addition to using a commercial respiratory phantom, we did need to construct our own cardiac phantom in order to simulate the motion we wanted to use. So here we have an image of the experimental setup, and I will walk us through all the components of it. So first we have a 3D printed scaffold, all these green parts, which were designed, consisting of a large platform shaped to fit onto the respiratory phantom here. There's a rack and pinion here, which was designed to fit onto the stepper motor, and then a smaller platform attachable to the rack. There's also a cube here designed to hold a small ceramic ball bearing, which was used as our radiation target, and that was taped to the smaller platform just so it wouldn't go flying around. This large platform had slots to mount the stepper motor in 3 different directions. However, in this work, only the slot for motion parallel to the respiratory phantom motion was used, and that's the way it's set up here in this image. An Arduino program was written to take an input one-dimensional cardiac motion trace and some set heart rate, and then reproduce that motion. And then all of this was set up in conjunction with this commercial BrainLab Exact Track gating phantom, which is all the white parts down here. And here you can see the chest plate where we have these infrared markers so that this would move as though it's the patient's chest. So to see how exactly this actually worked, here on the left we can see a little video showing the cardiac phantom alone doing its little heart beating motion with an example trace. And here we can see the two phantoms moving in conjunction. Now here we do have it set up so that the cardiac phantom is moving perpendicular to the respiratory phantom, which is not how the experiments were done. But you can see the idea of the respiratory motion and the cardiac phantom motion being simulated simultaneously. And we did some testing to ensure that the cardiac phantom would reproduce the motion expected without any issues. Now, for the actual experiment, I used a single cardiac trace obtained from patient cardiac lead position data, which you can see here in red. Now, this trace was rescaled to the desired peak-to-peak amplitude and vertically shifted to be symmetrical about 0 millimeters. In this case, the peak-to-peak amplitude is 9, so that's what you can see here in green. And then it was finally horizontally shifted such that the trace start was close to 0, which is what you can see here in blue. The reason for this shift is just because with the way the cardiac phantom works, it will mess up a little bit if the start isn't fairly close to 0, so that shift was just done to make sure that doesn't happen. Then for the study, we had 3 amplitudes we chose, 3, 6, and 9 millimeters, and a heart rate of 65 beats per minute were used throughout. Now, this cardiac phantom was set up such that the motion would occur in the superior-inferior direction, which is parallel to the setup of the respiratory phantom, also set up to simulate motion in the superior-inferior direction. So for the respiratory motion, 8 respiratory traces were obtained from STAR patient data. Now, the respiratory phantom was a bit finicky and had some issues with properly simulating the trace, So in order to deal with one of those issues, the traces were interpolated to upscale the sample rate from 5 to 30 hertz, which is why you can see here the raw data in black is a bit more spaced out than these blue X's, which are upscaled. And then one of the major problems with the software, I suppose, that runs the respiratory phantom was that it performed an automatic truncation in order to match the initial and final boundary conditions of the trace such that it could be looped. And as you can see here with the raw data, clearly these initial and final points would not be able to be cleanly looped. But the software didn't perform this truncation optimally and cut off far more of the trace than necessary, to the point where sometimes we would only have like a single breath in that it was looping. So I wrote some code to manually truncate the trace to maximize the usable length, which is why you can see that this blue trace is truncated in such a way that it can be nicely looped. Now, combining the 3 cardiac and the 8 respiratory traces, a total of 24 unique cardiorespiratory traces were simulated. An example with the largest amplitude trace combination is shown here. So this most extreme example is the one I will continue using for examples throughout this talk. So we have the 9mm cardiac trace shown here in red, and then the patient number 7 respiratory trace shown here in blue, and then those superimposed upon each other give us the full cardiorespiratory motion shown in green. Now, after this was done for all of the 24 combinations of traces, I suppose, data was also collected for hypothetical scenarios with no cardiac motion for each respiratory trace, and those are labeled as 0mm cardiac amplitude traces for convenience. So now that we've covered the setup of the experiment, we can talk about how the data was collected. Now, before we can discuss that, though, we do need to go over how a linear accelerator works. So this is a schematic showing the main parts of a linear accelerator, specifically one with a C-arm configuration. Now, details may vary depending on the exact type of LINAC. For example, O-ring LINACs wouldn't have this bending magnet here, but the general components and functioning are the same across them all. So as an overview, first, we have an electron gun here, which fires electrons down an accelerating waveguide, and the electron path is shown here by the red line. And this accelerating waveguide uses radio frequency waves in order to accelerate the electrons. Now, a magnetron or klystron down here is used to amplify radio frequency waves and send them down a radio frequency waveguide to the accelerating waveguide. A circulator, here in between, prevents reflections of those radio frequency waves since those could damage the equipment down here. And then we have a modulator, which synchronizes the radio frequency wave source and the electron gun in order to make sure that the electrons are surfing the wave properly. In order for the radio frequency wave to actually accelerate the electrons, it has to be timed correctly with the electrons, and it can be imagined kind of as a surfing type thing. Now, once the electrons make it down here, we often have a bending magnet to redirect the electrons to the target, but again, that depends on the exact configuration of the LINAC. And then the treatment head configuration also depends on a few things, especially whether an electron or photon beam is being used. But the overall concept is the same across most of them. For a photon beam, we would still have electrons up here, but an X-ray target would be used here, which then, when bombarded with electrons, would produce photons. For an electron beam, this X-ray target would not be here. But the important part of the treatment head that I do want to point out is the collection of collimators. So we have primary and secondary collimators here, and for a photon beam configuration as is shown here, we also have a multi-leaf collimator. And all of these are used to properly focus and shape the beam to exactly what we want to target. Now, in addition to focusing the beam, we can also position the beam relative to the patient in a few different ways. For this type of LINAC, it has gantry rotation, which means rotating about this axis I'm tracing out here, so it kind of rotate into and out of the page, as well as shifting around the couch that the patient is on. Now, the linear accelerator that I used for my work, which has unfortunately since been decommissioned at BC Cancer, is the Vero 4DRT linear accelerator. And here you can see it is an O-ring LINAC, so a bit different than the one I was describing before. Now, this accelerator is particularly cool because it is capable of real-time respiratory motion correlated tumor tracking, as well as non-coplanar treatment beams. It comes with a software system called the ExactTrack software system, which is used for initial setup verification, generation of the correlation model, as well as executing treatment delivery. Now, to go over how exactly this works again, for the dynamic tracking process, there is an external motion surrogate, which for us was an ExactTrack respiratory infrared marker pad, which would be placed on the patient's chest, and then that is monitored by the ceiling-mounted infrared camera. Then this motion is correlated with the motion of an internal surrogate, obtained simultaneously using a fluoroscopy sequence. Then during treatment delivery, the external motion surrogate continues to be monitored by this camera, which is used to then predict the motion of the radiation target using that correlation model. And then internal images are obtained periodically throughout treatment to verify the accuracy of the dynamic tracking. So for our study, we have 2 dynamic tracking scenarios we tested. In the first scenario, the internal-external surrogate correlation model was trained on the combined cardiorespiratory motion, which is labeled CR-T for cardiorespiratory trained model. Then in scenario 2, the model was trained on only the respiratory motion, labeled RO-T for respiratory-only trained model. Now, for that model, we turned off the cardiac phantom during correlation model training, which mimics a mathematical procedure wherein the cardiac component of the patient's cardiorespiratory motion is filtered out prior to building the correlation model. Because, again, of course, we cannot turn off a patient's heart during this treatment. I feel like that would be unethical. Do also note that no CRT data was collected for the 0 millimeter cardiac amplitude traces, as it would be identical to the ROT scenario since it doesn't involve any cardiac motion. Now, as an example, or I guess a visual guide through that cardiac filtering process I mentioned, this kind of shows the general idea of what it does. Again, I did not actually do this, I just turned my phantom off, but it is an important concept to be aware of. And the main idea of this is that it takes advantage of the fact that cardiac motion and respiratory motion periods or frequencies are quite different. So using some bandpass filtering and fast Fourier transforms, we can actually separate the 2 components out from a single signal. Now, for the actual experiment we did, upon a completion of dummy treatment deliveries, an automated exact track delivery log was generated, and that includes information about the generated correlation model and absolute localization errors of radiation delivery location from the predicted target location. And these localization errors are recorded at 1 Hz for the duration of dose delivery, which is why you can see here about 1 data point for every second. Now, do note that these delivery logs provide no directional information of the delivery errors whatsoever, only the absolute distance in 3D space, which is why here you just see some deviation in millimeters over time. Now, actually getting the data from these graphs was a bit of a nightmare. There's no corresponding spreadsheet with the numerical data, so initially I went on a bit of a detour and I used MATLAB to do this cross-correlation image extraction of the data points, but thankfully one of my coworkers eventually found the LaTeX files corresponding to these PDFs. But then that was another headache because the data wasn't actually contained in its raw form. Instead, there were X and Y values in pixels for drawing this graph, so I had to convert those to the desired units of time and distance using these labeled axes for scale. But once all of that was done and we had our data, there was also the issue of the no tracking scenario. So data wasn't actually collected using the Vero-Linac for scenarios with no dynamic tracking enabled, which is an important category to have so we can actually compare how well our correlation models did. But instead, distributions of position discrepancies for hypothetical treatments delivered with no tracking enabled were calculated by convolving the position distributions of each individual cardiac and respiratory trace, and these are labeled no tracking, or NT. And to give a better idea of how exactly this worked, first, both the cardiac and respiratory traces were vertically centered about 0 prior to finding their position distributions and performing the convolution. So I would center those traces about 0, find their position distributions, do a convolution of those 2 traces, and then because the exact track delivery logs only output absolute distances of deviations and didn't give any directional information, I also took the absolute value of the convolutions in order to match that data output for comparison. So here we have that same example trace from before, 9mm cardiac trace and the patient 7 respiratory trace. And I've plotted the absolute value of the position distributions for both, and along with the resulting convolution that I did. And again, these position distributions were, they had negative values, so they at least had that directional information prior to performing the convolution, and then just to plot it, everything was absolute valued, which is not a real verb. Then, for data processing, all of the collected ROT and CRT absolute localization error data was binned for each cardiorespiratory trace in order to form histograms and then plotted with the corresponding no tracking histogram. The mean and maximum values of each data set were also obtained. And then for each of the CRT, ROT, and no tracking scenarios, we also calculated a hypothetical 95% internal target volume, or ITV. So the 95% ITV would be the volume which covers 95% of the total volume in which the target motion occurs relative to the radiation beam. Now, again, since those data are limited to absolute localization errors with no directional information, these 95% ITV margins were calculated under a very simplified assumption that the motion occurred in a spherically symmetric manner. And then this was done by calculating the 95th percentile of the data distributions. So to explain exactly how that works, here's an example of a results graph. So we have the CRT and ROT correlation model, like distributions for the position discrepancies. And then as an example, for the no tracking convolution we have here, the 95th percentile of this data is about 13.3 millimeters. So a hypothetical 95% ITV for this scenario would be a sphere with radius 13.3 millimeters. So this is very simplified, but it does give us a measure for comparison to see, again, how well the two correlation model versions of dynamic tracking chalked up against no tracking at all. So now we can move on to our results and discussion. So the first exciting result is that a cardiac phantom was successfully built, which is great, and it'll hopefully be used for other projects down the line in the lab as well. But let's look at how the ROT and CRT models chalked up against no tracking. So there is a big table incoming. It's not the best for viewing purposes, and we will move on to graphs in a second, but just to show what the results actually were for the mean and maximum localization errors, here we have our output tables. So here we have the mean and maximum deviation for each of the motion traces, which are then grouped by cardiac amplitude, and then presented for each of the three tracking models. And then the mean and standard deviation of these mean and maximum deviations were calculated for each tracking scenario in each cardiac amplitude group. Now, to make this a bit easier to view, the data from the 8 respiratory traces were collated for each of the cardiac amplitudes and then plotted as histograms, which is what we see here. So we'll focus first on panel A here at the top left. So this is our 0 millimeter cardiac trace version. And so this has the collated data for the scenario with no cardiac motion during model training or treatment delivery, and this was used as a baseline comparison for just the efficacy of tracking respiratory motion alone. So pretty exciting results. The mean localization error was reduced by about 2 millimeters by using that respiratory-only trained correlation model for dynamic tracking compared to no tracking. And then the maximum localization error was reduced by about 5.3 millimeters, which we can see here in the graph. So we've got the reduction of 2 millimeters for this mean, which are showed by the dotted lines. And then you can kind of see the maximum trailing out quite far for no tracking versus the ROT model. So clearly this does support the efficacy of respiratory dynamic tracking for margin reductions, but how does it fare when we introduce cardiac motion? So now we can look at the other 3 panels as well. So here we have the 3 millimeter cardiac trace data in the top right. Panel C at the bottom left, we have the 6 millimeter trace data, and then at the bottom right in panel D, we have the 9 millimeter cardiac amplitude trace data. So with the exception of one cardiorespiratory trace in the ROT group, both models consistently reduced mean localization errors as compared to no tracking. And comparing the two models, these reductions were slightly larger for the CRT group, but the error bars overlap for the two, so we can't definitively say that one model was necessarily better than the other, but they both did improve compared to no tracking. And then looking at the maximum localization errors this time, again, there was one exception of a CRT cardiorespiratory trace, but besides that one exception, both tracking scenarios reduced the maximum localization errors consistently compared to no tracking. And this time, the ROT model reduced localization errors more than the CRT model, but again, they do overlap when taking into account the standard deviations, so no definitive way to say one is better than the other, but again, both are better than no tracking at all. And to really point out how effective this is, we can look again at that most extreme trace example, the patient number 7 respiratory trace with the 9 millimeter cardiac trace. So to give an idea of the magnitude of this, the half peak-to-peak cardiorespiratory amplitude of this trace was 20.7 millimeters. And when we look at the results, for no tracking, the mean deviation was 5.8 millimeters, but then got reduced to 2.7 and 3.2 millimeters by using a CRT and ROT model for dynamic tracking, respectively. And then maximum deviation, for no tracking, it was 17.5 millimeters, which got reduced to 6.6 and 5.1 by the CRT and ROT models, respectively. So pretty impressive reductions here. Now looking at our other measure of comparison, we also had those simplified 95% ITV margins, which are those hypothetical spherical volumes we would want to treat. So results here are presented as values equal to the radius of those hypothetical spherical volumes. And that's what we see here. So we have the 95% ITV volume radii, I suppose, for the no tracking in black, for the ROT model in blue, and then for the cardiorespiratory model in red. Now we can see pretty clearly that the CRT model did outperform no tracking, and the ROT model improved the margins even further, with the sole exception of this one FB8 9mm trace, where the CRT did a little worse than no tracking. If we look at that most extreme example again, that patient 7 9mm trace, the 95% ITV margin was reduced from 13.3 millimeters for no tracking down to 5.8 millimeters for the CRT model and 4.6 millimeters for the ROT model. Now, there is an interesting feature of these results that I'd like to point out. So the half peak-to-peak amplitudes of the respiratory traces ranged from 1.8 to 11.7 millimeters, which is a pretty wide distribution. But despite this wide distribution, the 95% ITV margins for both the CRT and ROT cases were narrowly distributed for each cardiac amplitude. So you can see here the no tracking are kind of scattered all over the place for each of the cardiac amplitude groups, but both the CRT and ROT ones are fairly narrowly distributed in each of the groups. Now, in particular, the ROT 95% ITV margins were within 0.4 to 0.6 millimeters of the half peak-to-peak cardiac motion amplitude across all traces. And to explain exactly what I mean by that, if we take an example of a 9mm cardiac trace, the half peak-to-peak amplitude of that cardiac trace would then be 4.5 millimeters. So what this is saying is that for each and every one of these traces, even though the respiratory trace parts of these ranged quite widely in their amplitude, each of these ROT 95% ITV margins were within 0.4 to 0.6 millimeters of 4.5 millimeters. And what this indicates is that the respiratory component of the motion was very effectively filtered out by dynamic tracking, especially using an ROT model. And to look at this numerically with all of the data collated again, here we have the mean values the mean 95% ITV margins for each of the cardiac amplitude groups. So, as we saw before, the CRT model reduced the mean 95% ITV margins compared to no tracking, and then the ROT model reduced those margins further. And here our error bars are much smaller, so we can actually say that ROT is better than CRT, and that is better than no tracking. Now, with all of these results, there is one major source of error that needs to be discussed. So a systematic error was introduced in the experimental setup. So between each trial, I suppose, or each cardiorespiratory trace we ran, the cardiac phantom would be reset so that it starts at a predetermined location. And so the cardiac phantom reset point was always the midpoint of the cardiac trace rather than the amplitude mean of the trace. And I will show a graph in a second to explain a bit more exactly what that means. But the reason why we care about this systematic error is that any systematic errors in radiation treatment delivery can result in underdosing. If we instead used the amplitude mean as a reset position, that would eliminate this systematic error, and it would likely reduce the mean absolute localization errors for the ROT scenarios, but would also likely increase the maximum absolute localization errors. So here we have a graph of the 9mm cardiac trace as an example, with an interpolation in red just to visualize the motion a bit better. And so the midpoint was 0 millimeters, so every time the cardiac phantom would be reset to 0. But the amplitude mean is actually 1.5 millimeters. So that means while we were running the experiment, the cardiac phantom would spend more time overall during the treatment delivery on this half of its motion rather than this half, because we used a physical halfway point rather than taking into account how long it actually spends in certain locations throughout the trace's trajectory. And this introduced that systematic shift. So now we can talk about the limitations of the study and our conclusion. So there was a very small sample size for this study, and all of the traces we used were only from men because VT does occur more often in men than women, so those traces were just what I had access to. But women are systematically disadvantaged by the medical research industry, and future work should absolutely include female patients too. Then real hearts and lungs do move in 3D space, they rotate, they deform, they have varying heart rates, but we used a single heart rate throughout everything, and Vero's tracking didn't have any directional or rotational information, only those absolute translational deviations of the target surrogate. In addition to all of that, in this study, we used a ceramic ball bearing for both the target and the internal motion surrogate. But in clinical settings, because the target wouldn't be readily visible on that X-ray imaging, instead, appropriate internal surrogates would need to be chosen such that their motion correlates to the motion of the target, such as ICD leads. Then for the ROT model scenarios, we carry those out by turning off the cardiac phantom during correlation model training, which assumes perfect cardiac motion filtering rather than actually mathematically doing that filtering. Then radiation targets are not perfect spheres, margins are anisotropic, and there are many, many different ways of calculating ITVs, also known as margin recipes. So future work would benefit from examining the impacts of using different margin recipes with more realistic target configurations. Then, of course, there's also that systematic error we just explained. And then this was a phantom study. So clinical studies applying dynamic tracking during actual STAR treatment will ultimately determine the clinical efficacy of this motion management method, and we'll need to consider issues as well, such as optimum patient setup workflows, which are not as relevant for phantom studies. In conclusion, striking a balance between delivering the necessary radiation dosage to a radiation target and sparing surrounding healthy tissues is a very key issue in radiation therapy. And targets affected by respiratory motion require motion management methods to minimize irradiation of healthy tissues. Cardiac targets are associated with the additional complication of cardiac motion. We found that the usage of dynamic tracking as a motion management method in stereotactic arrhythmia radioablation for ventricular tachycardia has the potential to decrease treatment margins, sparing healthy tissues from unnecessary radiation exposure. And we found that filtering cardiac motion out during respiratory correlation model training can further reduce 95% internal target volume margins. Reducing these margins and sparing healthy tissues from that unnecessary radiation exposure can reduce adverse side effects in patients and improve patient outcomes. So thank you everyone for listening, and thank you to all of the people who helped out with this project, especially my supervisor. And then of course I have a ton of references here, but yeah, thank you so much for listening.